Hi, this is Brian Wormers recording a lecture regarding safety for NUR 451, Management, Leadership, and Professional Issues. Well, as a nurse, there's going to be many times where you or your patients are not safe, and we've tried to minimize that and mitigate that as much as possible. And so today we're going to be talking a little bit about that. So we'll talk about incident reporting. We're going to talk about trying to prevent errors through the IOM's report, as well as crossing the quality chasm. We're also going to talk about legal topics such as malpractice, negligence, torts, those kind of situations. And then we'll talk about what happens if you see an impaired coworker. So incident reporting, so there's lots of different things that can go wrong in the hospital. In those situations, we need to report this. We report it so we can try and do better. Try to prevent it from happening, try to minimize it from happening, and be able to clearly document it to minimize, bad outcomes. So these can be medication errors, this could be treatment errors or procedure errors. This could be equipment injuries or errors, client falls, visitor or volunteer injuries, threats made to staff or clients, or a loss of property. So our role oftentimes is to document this and to, talk to the provider about it as well as submit it. This is often not a part of the medical record because you don't want to make this something that is punitive in the fact that you've done this 5 different times. Because in that case, then nobody's going to report. So we have to make it that it's a safe event to report, and that the goal is actually to promote safety, and so people feel safe in doing this. The other part with this is oftentimes these reports cannot be subpoenaed in most cases. This is an internal document for improving quality, and it's really meant to be a safe environment as much as possible. We make way too many errors in the hospital, and this is based on a couple of different things. But To Err is Human is one of those things that's trying to tackle this. It's through the Institute of Medicine, and it's talking about all different aspects of healthcare. We're trying to create a focus on safety, trying to prevent and learn from errors, and then raise performance standards, and then implement safety systems. So I will say that To Err is Human is an older type of a document, but it's still being referenced by the local hospitals here, and that's why we continue to mention this, because you might hear it at the local hospitals. The other thing along with this through the IOM is crossing the quality chasm, so we want safe, effective, patient-centered, timely, efficient, and equitable care. That's really what we're trying to improve in healthcare. And this is really what we're trying, our goal is each and every shift. So IOM, if you read through this, I don't think it's groundbreaking on the things that we're trying to do, but the thing that it does, and it does nicely, is it tries to put all groups together, put a common language to what we're trying to do, and trying to move forward as a team. And that's really nice. So as we talk about some of the things that the nurses could do wrong, malpractice is one of those things if we fail to act in a reasonable and a prudent manner. So if other nurses would do it, if this is against their policy and protocol, then of course this is something that we can get in trouble for. So if we fail to act as we should act, there's responsibility that we have with our job, and there's consequences for not doing what we're supposed to be doing. Negligence is when you had the duty to provide care, you breach that duty, there's foreseeable harm that could happen for you not doing what you're supposed to do, and then harm does occur. And so within this, that's negligence. So when you get a responsibility and you don't do what you're supposed to be doing, that. So how do we avoid this? Well, follow your policy and procedure. That's the biggest thing. Give competent care. So know what you're doing, why you're doing it. Have good communication with that patient and with providers and with those people that you interact with. Develop a rapport with the client, and then fully document everything. I will say that if you get called into court, oftentimes you won't remember what happened 2 years ago. And it will be your documentation that will help bring up some of these memories and can help fill in the gaps that you might not remember otherwise. The ANA does say that every nurse should carry their own professional liability insurance. That's going to be up to you. Even if they're covered by their employer, there's some debate about whether that will be truly effective for you, or if that insurance is going to cover more for the employer than for the nurse. So I think it is good. I know my wife carries it, and when I was practicing, I carried it, and I think that that's a good thing. But you can research it and you make your own decisions on this one. Quasi-intentional torts or intentional torts. So invasion of privacy. So if you are looking through somebody's medical record just because you're curious and you're being intrusive, that's invasion of privacy. Assault is causing or threatening physical harm to another person. Battery is physically touching them, being aggressive, or by something that you threw at them, or struck them with something. False imprisonment is any person who knowingly or purposely restrains another person unlawfully. So, if you're looking at this one, a nurse witnesses an assistive personnel under her supervision reprimanding a client for not using the urinal properly. The AP threatens to put on a diaper on the client if he does not use the urinal more carefully. What do you think this is? So since they're really not touching them or doing anything, it's probably not battery. False imprisonment, not yet. I have heard of some people call that being in a diaper is false imprisonment, or restraining them to their bed, of course, is false imprisonment. Invasion of privacy, not really. But if they took off their clothes, then that could be invasion of privacy. But it's definitely an assault. You're threatening of somebody. So, client had a procedure but refused it. Nurse insisted and inserted NG anyways. So within this, the hospital will probably settle the lawsuit as quickly and quietly as possible, because the nurse is probably guilty of what? And it's battery, because you physically assaulted somebody. You did something to them that they didn't want to have done. So client rights. So clients should be informed of all aspects of their care, and they should take an active role in the decision-making process. That means that we as nurses have to educate them well, give them those choices, and help them make those choices. Not that we can just do it for them and be very paternalistic. They've got the right to refuse, accept, or modify the treatment plan. And they can receive care that is delivered by competent individuals. I mean, I would hope so. And then they have right for an informed consent. What are the pros of this? What are the negatives of this? And do you want to have this done? So if you're the nurse and the provider tells you that they've got to have the consent signed prior to procedure, but you weren't there, what would be the best way for you to do this, to advocate for the patient? Do you think the doctor's asked you that you sign the consent form? Is that how you can present it to your patient? Do you have any questions about the procedure? What were you told about the procedure? Or remember that you can change your mind to cancel the procedure. Well, I mean, that's true. That's kind of alright. That's true. But the best one is you're doing your teach back method here. What were you told about the procedure? So hopefully they understand who's doing it, what's being done, and some details about the procedure in and of itself, without prompting them. If you just ask this one, chances are they're going to be like, no, and they won't really have thorough discussion or be completely honest with you. Now this is a really hard topic. So impaired coworkers, more and more what we're seeing is that there are healthcare providers that are impaired. And so what would you do? What would you do if somebody that you knew was a friend of yours or a colleague or coworker of yours is under the influence? And that could be from medications, drugs, alcohol, whatever. But if they're impaired, you do have a responsibility, of course, to talk about this. And then we'll talk about some signs and symptoms of abuse. So within this one, so what do? Well, take it up the chain. Talk to the manager, talk to the director, talk to somebody. I mean, if you feel comfortable, you can talk to them about it, but I don't think that that's probably going to be the resolution to this one. I think that you've got to go higher up and you've got to let it be known. And do it. You don't have to build a whole case against them. You don't have to have 15 articles on display saying, hey, this is why this person is, I believe, is under the influence. But if you've got some kind of thoughts or some kind of feeling, let somebody else know. And of course, the worst thing is we don't want to make sure, we don't want to like say that they are and they're not. But at the same time, we're there to protect the community and our patients. And if they're under the influence, they might not be able to do that. So what are some signs and symptoms of abuse? Well, change in appearance, change in mood. Maybe they're gone on their shifts. Maybe they're disappearing. Maybe they're asking and trying to help people give narcotics or requesting care for the patients that have got the narcotics. Maybe they are sleepy. Maybe they're unresponsive. I mean, there's a whole host of things that can be signs and symptoms of substance abuse. So as we look at this, behaviors have changed over a month. What could indicate signs of an impairment? All that apply. Absent from the nursing unit during the shift. Yeah, they're ducking out, trying to get a drink of alcohol or take meds. Interact well with others? Maybe, maybe not. That one's kind of indifferent. I hope they can, but that really is not telltale of one or the other. I mean, if they're too far down the pathway, then of course they're not going to interact well with people. So I would say A is something you'd want to watch for. B is something not. Forgets to sign out. Administration controlled substance, big red flag. So A and C so far. Offers to administer PRN opioids for other nurses' clients. Yep. So that's providing them access. And then is able to say no request to work more shifts. Honestly, that's probably opposite. If they are truly addicted and they are looking for ways to get narcotics, then they're going to be working every chance that they can so they can be in a position where they can get it. So on this one, I would say A, C, and D. But having, concerns like that is, unfortunately, it's real. Unfortunately, I've talked to people on the board of nursing. It happens quite a bit. You can, when you are a registered nurse, you'll get a flyer or a little newsletter, and in there you're going to see, letters of reprimand and different things like that. And you can see people that have gone down this pathway. So be careful with that. If you suspect somebody, take it up the chain, let them know, and protect your patients. All right. If you have any questions on this, please let me know. Otherwise, I hope you have a great day.